Hello everyone, welcome back to Channel Essentials of Acute, Emergency, and Critical Care. Today we're discussing hypomagnesemia, one of the most commonly overlooked electrolyte abnormalities in clinical practice. Magnesium is often called the forgotten electrolyte, yet its deficiency can lead to life-threatening arrhythmias, refractory hypokalemia, refractory hypocalcemia, seizures, and neuromuscular dysfunction. Many patients with hypomagnesemia remain undiagnosed because magnesium is not routinely checked, and importantly, a normal serum magnesium does not always exclude total body magnesium depletion. In this video, we'll cover physiology, causes, clinical manifestations, diagnosis, ECG findings, treatment, and important clinical pearls. Let's begin. The adult body contains about 24 grams of magnesium. Approximately 60% is stored in bone, 39% inside cells, and only 1% is extracellular. Normal serum magnesium ranges from approximately 1.7 to 2.4 milligrams per deciliter or 0.7 to 1 millimole per liter. Magnesium acts as a cofactor in more than 300 enzymatic reactions, including ATP production, DNA and RNA synthesis, neuromuscular transmission, cardiac conduction, potassium transport, and parathyroid hormone secretion. This explains why magnesium deficiency affects almost every organ system. The causes can be remembered in three major categories. Number 1. Decreased intake. Examples: malnutrition, alcoholism, starvation, eating disorders, and elderly patients. Number 2. Gastrointestinal losses. Chronic diarrhea, vomiting, high-output stomas, short bowel syndrome, chronic proton pump inhibitor use, and pancreatitis. Long-term PPI therapy is an increasingly recognized cause because it impairs intestinal magnesium absorption. Number 3. Renal magnesium loss. Common causes include loop diuretics, thiazide diuretics, cisplatin, aminoglycosides, amphotericin B, calcineurin inhibitors like tacrolimus and cyclosporin. Inherited disorders include Gittleman syndrome, Bartter syndrome. Poorly controlled diabetes also increases urinary magnesium excretion. Symptoms depend on both severity and speed of onset. Patients may develop neuromuscular symptoms: tremors, muscle cramps, weakness, tetany, hyperreflexia, positive Chvostek or Trousseau sign, and seizures. Hypomagnesemia is particularly important in ICU patients because it increases the risk of atrial fibrillation, ventricular arrhythmias, torsades de pointes, and sudden cardiac death. Hypomagnesemia causes refractory hypokalemia. Unless magnesium is corrected, potassium replacement alone often fails. Similarly, low magnesium impairs parathyroid hormone secretion and action, leading to hypocalcemia that is difficult to correct. ECG findings may include QT interval prolongation, ST depression, flattened T waves, ventricular ectopy, and torsades de pointes in severe deficiency. Always check magnesium in any patient presenting with unexplained prolonged QT or ventricular arrhythmias. Diagnosis begins with measuring serum magnesium. However, remember this important limitation. Since only about 1% of total body magnesium is present in extracellular fluid, serum magnesium may appear normal despite significant intracellular depletion. Additional investigations should include serum potassium, calcium, phosphate, renal function, and ECG. When the cause is unclear, measuring 24-hour urinary magnesium or calculating the fractional excretion of magnesium, FEMG, helps differentiate renal from gastrointestinal losses. The value greater than 3 to 4% suggests inappropriate renal magnesium wasting. Treatment depends on symptoms and severity. Asymptomatic or mild hypomagnesemia. Oral magnesium is preferred. Examples include magnesium oxide, magnesium chloride, and magnesium lactate. Be aware that diarrhea commonly limits oral therapy. Symptomatic or severe hypomagnesemia. Patients with seizures, significant arrhythmias, torsades de pointes, and hemodynamic instability require intravenous magnesium sulfate. A commonly used regimen is 1 to 2 grams intravenous over 15 to 60 minutes for symptomatic deficiency. For severe depletion without an immediate emergency, 4 to 8 grams intravenous over 12 to 24 hours is often administered, with dose adjustment in renal impairment. After serum magnesium normalizes, continue replacement for another 24 to 48 hours because intracellular stores replenish slowly. Simultaneously, stop offending medications whenever possible. Correct potassium and calcium deficiencies and treat the underlying cause. Before we finish, here are 5 high-yield take-home messages. Always suspect hypomagnesemia in ICU patients, alcohol use disorder, chronic diarrhea, and long-term PPI therapy. Refractory hypokalemia is magnesium deficiency until proven otherwise. Hypomagnesemia can cause refractory hypocalcemia through impaired PTH secretion and resistance. QT prolongation with ventricular arrhythmias should prompt immediate magnesium assessment. Correct the underlying cause, not just the magnesium level. Hypomagnesemia is far more than a laboratory abnormality. It is a clinically significant electrolyte disorder that affects the nervous system, cardiovascular system, and electrolyte homeostasis. Early recognition and timely correction can prevent serious complications, including fatal arrhythmias. If you found this video useful, please like, share, and subscribe for more evidence-based videos on critical care, acute care, and emergency care. Thank you for watching, and I'll see you in the next video.